Good afternoon. Thanks for joining us today to learn about billing for prolonged services. This webinar is a joint production of Pennsylvania Medical Society, our subsidiary, the Care Centered Collaborative, and our partner, Formative Health. During today's session, we're going to cover which payers are reimbursing for prolonged services, how and when it is appropriate to bill for prolonged services. We're going to talk about the workflow, and you can incorporate billing for prolonged services into your practice. And of course, we will review what's required when you are documenting that you provided prolonged services. Now, if you haven't recognized my voice yet, allow me to introduce myself. My name is Jennifer Swinich, and I am the Director of Practice Support at the Pennsylvania Medical Society. Joining me today is Danielle Tamuti. Danielle is the Manager of Client Success at Formative Health and is a certified professional coder. She's also a certified evaluation and management coder. Formative was selected as a partner to assist practices in need of revenue cycle management and other management services. I have just a few disclaimers before we get started. As we all know, payers change policies. What we're presenting today is up to date as of this time, so please be sure to check payer policies for future use. Now let's get started. So we're going to start off with some payers and some policies. If you're curious about exactly which payers are reimbursing for prolonged services, we put together some preliminary information for you. So this chart is going to list some of the common payers in Pennsylvania and their associated plans, and where we had access to the information and the types of plans, we've listed it. So you're going to see columns for the different types of prolonged services. You'll see that we're going to talk about policies in the outpatient setting, in the inpatient setting. There's prolonged services when you're adding them either before the face-to-face or after the face-to-face without the direct patient contact during that time. In some instances, you can bill for the clinical staff time, and then there's prolonged services for preventive services as well. So there's a whole lot of different variations and variables here, and that's why we wanted to list these out for you. So with Aetna, you'll find that we really don't have a response in there. Aetna did not have policies available on this, and when we reached out to them for clarification, we haven't had a response. So we don't have information on Aetna, but I do want to move forward to Capital Blue Cross. Capital does have some policies online, and they did confirm some of these items with us, and typically they're following CMS guidelines. With the exception of their Medicaid plans, Medicaid is not one of the payers in either the fee-for-service or the MCOs where prolonged services are covered. With Cigna, you're going to see some blanks in there as well. Cigna did not reply to our requests and did not have policies online. With the exception of preventive services. Preventive services, they did have a policy available. They did not acknowledge the other types of prolonged services. So that's, and when we reached out for confirmation, we did not receive a response. Geisinger is also keeping us in the dark. But I do want to let you know about Highmark Blue Shield. You'll see that they do not cover it for their commercial plans, but they do cover it for Medicare in the inpatient and outpatient setting. So let's move on to the next group of payers. And Independence Blue Cross, they do cover it in some instances for commercial and Medicare, just not for the non-patient facing time, when it's before the visit or after the visit. As you heard me mention before, Medicaid does not cover it in any instance. Medicare Part B does cover it, and that's what sort of is, prompted all of this when Medicare added this to their physician fee schedule. I believe, Danielle, it was 2018 that they did that, right?
2017 and
2018.
Yep.
Perfect. Moving on to United Healthcare. United Healthcare pays it for their plans, with the exception of the preventive visits, and then UPMC pays for it in all instances of prolonged services up through Medicaid. So that's just a brief overview of which plans are actually recognizing and reimbursing for it. Now, I want to move on to let you know that you have an opportunity as a member of PA Med for a free revenue cycle analysis. This information is coming to you today through PA Med, but with our with our partner, Formative Health. And Formative Health will conduct this free revenue analysis to let you know if there's opportunities like this where you're leaving money on the table. So if you are interested in taking advantage of this complimentary offer, you can contact Anita Brazil at our Care Centered Collaborative at the phone number and emails that are on the screen. So moving forward, I'm going to turn this over to Danielle to talk about some of the specifics with prolonged services.
So thank you so much, Jennifer. I appreciate the introduction. And it's exciting that so many of the carriers are now paying for prolonged services and following Medicare's lead. And so we're going to talk today about how and when to bill the prolonged services. And it really, now that there are more than one type of prolonged service covered, it's just going to be dependent upon the place of service, the provider of service, and the type of service. That each prolonged service must go beyond the usual service and is billable and payable now by most carriers, which Jennifer just went over with you. So an E&M visit may go beyond the usual service because, so these are the scenarios when you would bill prolonged services. A non-compliant patient, for instance, a patient has difficulty understanding and needs further explanation, or maybe they even have handicaps or language barriers. Complex treatment options, such as major surgeries, chemotherapy, life-changing events, and explaining lifestyle or activities of daily living changes. And when the provider identifies a patient with the complex problems, try to coach your provider that these are services that are now payable. So start watching that clock so that they can track the time that they have spent with the patient. I know some EHRs do a great job of giving timers in the notes, but some do not. So the providers really need to be proactive in starting that timing and being aware of how much time that they're spending with the patient. And the note needs to also state in there, as with any time code, spent total time of 75 minutes with the patient, of which was spent counseling and or coordinating care regarding. And you can go ahead and put that information in there, and then the visit start and stop time, so that you have all of the documentation that supports your time codes. The direct patient contact, many of you are probably familiar with these codes, although they weren't always paid. They are your typical prolonged service codes, and these are add-on codes to evaluation and management codes. So you need to build the primary E&M code before you bill your evaluation and management, before you bill your prolonged services. So the first code there, the 99354, is prolonged evaluation and management or psychotherapy services, so it is for both, beyond the typical time of service. So the typical time can be found in your CPT books, and or if you use one of the CPT tools, each E&M code has a typical time indicated in the description. And those are used for when you bill E&M services by time, and or when you have these types of add-on situations. So the clock would not start for these services until the typical time of the evaluation and management time would be up. So the first code there is for the first hour, and the second code, the 99355, is for each additional 30 minutes. So and they must always be reported in addition to the E&M service, which I went over. But they can never be reported without a code, without a listed typical time as part of the descriptor. So these particular prolonged services would not be billed with your preventative medicine codes, but we'll get to a code that you can bill with those now, just starting in 2018. So, and they may not be reported in addition to prolonged clinical staff services. So we now also have clinical staff prolonged services that are covered, but you can't bill both the clinician and the clinical staff together. And that kind of makes sense. I mean, you know, it would be overlapping. So the 99354 and the 99355 are used to report the total, and this is face-to-face time spent. So that is, face-to-face with the provider or the physician, and providing the prolonged service in addition to the E&M services. Either code should be used only once per date. So even if the time by the physician or qualified healthcare professional is not continuous on that date, so it's just like other services, it does still need to be face-to-face time. And prolonged services of less than 30 minutes total duration cannot be billed separately. So you must get at least 30 minutes in, and that is Medicare's typical role. So your 99354 is for the first hour. And what this rule is saying is you have to get past that 30-minute mark before you can bill that first unit of prolonged services. So an example of when you can use this code is a physician performed a visit that met the definition of a 99213, and the total duration of the face-to-face time, including the visit, was 65 minutes. So in this scenario, the physician can bill the 99213 with an additional unit of 99354. The reimbursement for these codes are pretty good. So the first hour, the average reimbursement for those carriers that do cover it is $138, and for each additional 30 minutes, it's $104. I also included a prolonged service table in here for you so that you can see what those typical times are. So that first column there is your new patient office-based visits. You can see that's the first codes that are listed, and those typical times are taken from the CPT book. So that's what you have to get past that time. And then I also in this table gave you the threshold of when you can start billing the prolonged services and the additional units of prolonged services. So it's a nice little table to give the providers too, because it would makes them aware of what that typical time is so that they can also be aware when they need to start that clock. The next codes are for inpatient and observation settings. So we also have prolonged services in those scenarios. And this is actually defined as, intra-service time and unit and floor time. So this does include both the face-to-face and unit and floor time. It includes the time that is established and or to review the patient's chart, examine the patient, write the notes, and communicate with other professionals and the patient's family. So it does include all of that time spent for the provider. It is an add-on code, just like the face-to-face outpatient. And the first code is the 99356, and that is for the first hour. The average reimbursement for that code is $120. And the 99357, which is the additional 30 minutes, is $57. And those are averages. It's going to vary depending upon the carrier. Like the first codes, you need to at least get halfway through that first time. So it's a minimum of 30 minutes. Anything less than 30 minutes cannot be reported. And for an example of this, the patient with a cardiac arrhythmia who you suspect may have an emboli. That's a great example of when you're going to be spending a lot of extra time with the patient, and would be a scenario that you could utilize these particular codes. I also included a table for the inpatient and observation services. So you see your hospital visits there on the left, the typical time for each one of those, and then your thresholds of when you can bill that prolonged service time. The prolonged clinician services without direct contact. So you'll utilize these codes when it's not face-to-face or when it's not part of the unit or floor time, but the patient does have to have a face-to-face encounter before or after, so that for you to utilize this code. And you cannot bill it. Anything less than 30 minutes cannot be billed. So it follows the same guidelines as the other professional prolonged services. And then prolonged preventative services. So this code is new in 2018, especially for Medicare. Medicare announced this, but other carriers are covering it, as Jennifer went over in her spreadsheet. They are G codes at this point. So that first one, the G0513, is prolonged preventative services beyond the typical time of the primary procedure in the office or outpatient setting, requiring direct patient contact beyond the usual service. And that's the first 30 minutes. And you would list this in addition to the preventative services. So this is great because we know that we are spending a lot of time with patients on preventative care and preparing for all of our MIPS and quality measures and all of the processes that go around that. These patients are, even though these are preventative services, they are taking a lot of time with the providers. So this is a great way to get reimbursed for that time. And again, coach your providers, let them know that these are now services that are covered. The G0514 is prolonged services. It's each additional 30 minutes. So it's that first code is the first 30 minutes, and then each additional 30 minutes is your G0514. It pays about $63 for each. And so an example that I would give is during the initial wellness visit, the physician reviews the health risk assessment, screenings, and past medical, family, and social history with the patient. And in developing the personalized prevention plan, the physician spends a total of 50 minutes. So meeting the patient, 30-minute threshold for the wellness visit, and then the 20-minute threshold for the prolonged service. You can go ahead and bill both your wellness visit as well as those prolonged services, and then it will cover the time with discussing the risk factor reduction, the importance of flu vaccination screenings, discussions about reviewing reasons for having screenings done, reviewing the patient's history. So everything that goes along with the preventative services, and they are not subject to the copay or the deductible. So that's nice. The patient isn't going to have additional out of pocket. It's going to fall right under that preventative service, and that's for Medicare. So other carriers may vary, but for Medicare, that it would not be subject to your deductible or copayment. And so that's a great option now that the that Medicare is paying for that. And what I did here is just put the prolonged preventative services that you could utilize those prolonged service codes with. So you can see your welcome to Medicare, your initial annual wellness, subsequent annual wellness, your PAP screening. So you can see each one of these different services you can, you're eligible to then bill those prolonged services. And here are several more as well that you can bill. And I did put the thresholds in there too. So for those time codes, and then the thresholds of when you can bill those preventative services in conjunction with your screenings. Now, this is very exciting, although it's not a high paying code. At least they are covering this service, and it's prolonged clinical staff service. So your ancillary staff, you can get reimbursed for. And so that first code is 99415, and it's prolonged clinical staff service. It's the service beyond the typical service time and during an evaluation and management service in the office or outpatient. Direct patient contact with supervision, physician supervision first hour. So basically the physician does have to be on site and readily available. And you would list this as an add-on code to the evaluation and management service. That first code is for the first hour. So it's going to follow the pretty much the same table as the physicians do. And the 99416 is for each additional 30 minutes. That clock starts just like it does with the clinician face-to-face time. It starts after the typical time of the E&M code. Now, for these codes, they average about $8 reimbursement for the first one, and I know all of our ancillary staff is worth more than that $8, but at least it helps cover the overhead of the office and offset some of those expenses that you have to absorb in providing these services. So it's $8 for that first hour, and then for each additional 30 minutes, it averages 50 cents to $1. So it's going to vary. That's what Medicare's reimbursements are. So an example of this one would be the physician remains available in the office suite during the service, so they have to be on site, and the nurse or the medical assistant spends a total of 95 minutes with the patient. During the 2 hours, let's assume that the physician's E&M service reported was a 99214, so it was a level 4 office visit, which typically involves about 25 minutes face-to-face. So the nurse's face-to-face time was 95 minutes, is reported as 70 minutes because you do subtract that typical time. So a prolonged clinical service, because the prolonged service clock starts after the typical time. So that gives you an idea of how you would report this. And it's basically the same table that I put there for you so that you know when you can bill your first and second units there. A physician or a qualified healthcare professional does have to be present. So it is direct supervision, meaning that they have to be on site. You would not report this. So there's a little bit of a different regulation here. You would not report this on more than 2 simultaneous patients. So, you know, you don't want to be billing this for every patient in the office at the time. There is a limitation to that. And you would not report it in conjunction with the provider's prolonged services, which we talked about, the clinical services. And then I just have another example here. You know, a 2-year-old presents with vomiting and diarrhea. Mother states no wet diapers in several hours. So it just goes through some scenarios of when the staff would spend more time with the patient, which I'm sure you are all very well aware of. And in this particular instance, this patient was given, you know, oral rehydration, so the nurse was with the patient. So scenarios like that would definitely support the need for the prolonged clinical staff service. So thank you so much. We're going to go ahead and open up today's presentation for questions, and Jennifer and I will do our best to answer those for you.
I have a few questions here, Danielle, if you don't mind if we get started. And I'm going to take the first one. The question says, where can we get information on chronic care management codes? And I want to let you know that as PA Med members, you can contact us with these types of questions all the time. Our Knowledge Center is here to take those questions. We do have resources on chronic care management, so I encourage you to call us and we will get you that information. Or you can email us as well. That's knowledgecenter@pamedstock.org. And the phone number is 1-866-PA-MED, PA-MED4U. That's 1-866-PA-MED4U. For our next question, it's regarding code 99358. For code 99358, does the face-to-face have to be within a certain time frame? For instance, 24 hours?
No, it's not required. It just has to be within the before or after the visit and pertaining to that face-to-face visit.
Okay. And then I have another question that came in, and it asks about cost sharing. What is the cost sharing to the patient when prolonged services are billed?
It's going to add-on code, so it's going to follow the same benefit structure as your E&M services do. So the E&M service would be the primary code, and most plans will, maybe apply a co-payment to that E&M service, and that would cover the visit because the prolonged is an add-on service to that primary code. We're seeing more and more plans now, though, with office visits applying to the deductible before the co-pays kick in. So in those scenarios, then both of the services would get applied to the deductible at the allowed amount.
I want to make a correction. Our 800 number is 855 PA Med for you. 855 PA Med for you. And don't see any other questions. If you have any other questions, go ahead and type them in here.
One others, and Jennifer, they're asking, can we get a copy of the presentation and or recording of the presentation? So.
Yeah, absolutely. We are going to be sending slides out to all of our attendees today, and we will have a copy of the webinar that's going to be available on our website. And we have another question that came in. Are there any concerns on how often prolonged services are charged? We have a physician that typically spends a lot of time with patients who have developmental issues where 99354 could be utilized.
So as long as your documentation supports the medical necessity and the time that you're billing, you should have no problem with an audit. Anytime, though, a physician specializes in one certain area, they tend to exceed their peers in some of their utilization of codes. So for those types of physicians that do, or providers that do provide very specialized services, they may get audited more often, but you can have peace of mind in knowing that your documentation substantiates the use of those codes. So just make sure that when the physician is utilizing or provider is utilizing and billing those prolonged services, that they're also, talking about the patient's disability or developmental issues in their notes that required the provider to spend more time with that patient, and then, make sure that you're also documenting the total time that you spent with the patient.
The questions keep coming in. This is great. For prolonged clinical staff services, can it also apply to front desk staff who might be doing referrals, making appointments with specialists, or any sort of time like that?
So in those scenarios, it has to be face-to-face. And it has to be related to the patient care. And I know I get this question a lot with prolonged services. Can we bill for the time it gets, for pre-authorizations and those types of things? No, because it's not related to the patient's direct care. Now, coordinating care with other physicians or referrals and those types, yes, that is included in prolonged services, and you just want to document that you did, perform that coordination of care and, with whatever physician it was and those types of things.
All right, another question came in. Does the time that's been documented need to be sent in with the claim?
No, unless the insurance company would request additional information, it's billed just as any other E&M service would be billed. So you would just add that to your claim form and submit it, and then just make sure that your documentation substantiates the units that you've billed.
All right, the next question is, do I have to add a modifier with the prolonged services? And if so, which modifier and what code is it added onto?
No, you do not need to add a modifier on the E&M service, so you wouldn't put like a 25 or anything on your E&M service, because the prolonged services are add-on services to the primary code. The insurance company is already expecting you to bill those two together, so it will not hit any CCI edits.
All right, and that's it for the questions. If there's any other questions, go ahead and get those submitted now. I'm not seeing any coming through. I hope you found this information valuable. Wow, I am impressed. We will get slides out to you. We will have the webinar recording available on the website if you want to come back and review the webinar again. And thank you so much for joining us today. Thank you, Danielle, for providing all of this valuable information to our practices. And thank you to our members for joining us on the webinar today. We hope you have a great day.